There she
Boop,
is.
boop. There
Hello.
she is. Hey, hey, welcome.
Okay, technology doing what it's
Right.
supposed to, what it does best, being
It's all
difficult.
good. It's all
Yeah.
good. Welcome, Dr. Milhouse. You need a
Hello.
second? You need a woo
No, no,
saw
no, I'm
for a
good. I'm
second?
good. Thank you. Thank you. Thank you. Yep.
Probably.
Obviously still in my office, working, but that's what we do.
That's what we do. That's what we
Yep.
do.
Yes.
So thanks for joining us. This is the fourth installment of the Love Below series. And
Awesome. I love the
so
title.
Oh yeah, thank you. I appreciate.
Yeah.
We just want to. I saw everything that you did on social media, and your drive, your passion to help women, especially be more confident about their pelvic health, their sexual health, and all of those types of things. And so the purpose of this series, the Love Below series, is really for me to talk to other physicians and those in healthcare with whom I collide as a colorectal surgeon and collaborate.
Yeah.
So our first week was fibroids and endometriosis specialist. Second week was a pelvic floor rehab therapist. Last week, no, 2 weeks ago was a GI doc because we took last week off, and so now we have you as a urologic surgeon. So if you could introduce yourself and just tell us
Sure.
about your passions and your why.
Yeah. So I'm Dr. Fenwa Milhouse. I'm a board certified urologist and I am subspecialized in female pelvic medicine and reconstructive surgery, also known as Urogyne. In urology, we deal with pelvic floor stuff because we are in that area already. We kind of take ownership of a lot of the pelvis, and
Hmm.
especially with my subspecialty, we get really, really deep into that. I have been uh bona fide out, post training a urologist for a little over a decade now. I see any adults who with anything between their legs. Um, I have a passions in multiple areas, but I will tell you my passions are sexual function in all individuals, but especially vulva owners, vaginal owners, because they've been extraordinarily neglected and still are. Um, I love fixing up pelvic organ prolapse, and I've been more recently really vocal about hormone therapy. So those are my niches. I have my own practice in Chicago called Down There Urology, which I'm quite proud of. And yeah, I've worked multiple times heavily with colorectal surgeons. Sometimes we'll find ourselves together in the operating room, fixing up a really bad pelvic floor case. I've done combination cases, rectocele, I'm doing like pelvic organ prolapse, maybe a rectocele, and then they also have rectal prolapse
Mhm.
themselves.
Yep.
Um, and oftentimes patients of mine come with GI complaints. Okay. I tell patients the pelvic floor is responsible for the three P's: peeing, pooping, pleasure. So I'm asking about bowel habits and a bunch of stuff if they're coming in for urinary complaints or sexual complaints.
Right.
I'm like, okay, well, how's your pooping and that sort of thing. So it's very collaborative.
Yeah, it's crazy how many women, before you came on, I was actually mentioning that as well. It's crazy how many women come to see me when they've had certain pelvic floor urological complaints, urinary incontinence, and then they later on come to see me for their bowel issues. And it's like they just had their surgery like last year. And I'm just
Mm.
like, did anybody ever ask
I,
about? Because we know.
yeah,
Like
exactly.
it's like we should have did it at the same time. We should have addressed it at the same time because we know, like at least from my standpoint, if someone has rectal prolapse or a really bad rectocele, if I only fix that and they have issues in
Other
the
things.
bladder or the vagina or the uterus, like my surgery has a 30+% chance of failing. And
Mm.
so like I haven't even helped you unless, so I do a lot of again combo cases with
Yes.
urology or GYN just to make sure that like you can't have one thing pulling down and then fix, it's literally a
Yes,
it's tug of
absolutely.
war.
It's yeah, yeah, yeah. We learned that pretty extensively and pretty early in urology, like
Yeah.
bladder symptoms. you have to screen or need to assess bowel symptoms.
Yeah.
Um, and um, you may have, find yourself referring patients to specialists like you. And like if somebody has chronic constipation, chronic issues, and I'm trying to treat their bladder and only zoned in on their bladder, and I'm missing something like, bowel dysfunction, that could be, the whole problem there.
Yep.
Um, yep.
Yep. Yep. Because we talk about, the pelvis is a fixed space. There's only so much, space that's down there.
Yes.
And so if they have any of those combinations of issues, it can impact the other. Um,
Absolutely.
so okay, hot topic that I know, like that we were angry texting about this week.
Yeah.
I shared with the audience my experience with the pharmacist refusing to fill the vaginal estrogen. So um,
Yeah.
tell us about the benefits of vaginal estrogen. And I know Sonia mentioned that there was someone who had a question in one of the chats or something that came in through DM regarding vaginal estrogen.
Yeah. I look, vaginal estrogen is that bitch. She is that bitch. She is everything we need. If you have a vagina and you get a little old enough, and sometimes it's not about age because there's other things that might prompt us to say you need vaginal estrogen. You will need it, but certainly, if you get past your 40s or into your 40s, you might find yourself having changes down there that are unpleasant. And the estrogen matters so much. Also testosterone, but for the simplicity of this, estrogen matters so much in the vagina and vulva. It helps reduce our risk of UTIs. It helps control urethral symptoms and bladder symptoms. It helps lubricate our vagina and allow for comfortable penetration. It helps maintain elasticity in our vagina. It helps our microbiome. It is important for blood flow. My dear smart, amazing colleague Rachel Rubin says estradiol is female Viagra. Okay. It improves blood flow. We know we see the changes. If you examine women and take care of women, you already see the changes if you in their vagina and vulva over the time. You can
Hmm.
tell, I know you can even say, even though you're colorectal, a 50, 60, 70, 80-year old vulva vagina looks different
Yep.
than a 20, 30-year old.
Yep.
And it's not just about looks, but the changes are stark, but that actually translates into functional decline.
Right.
So you have thinning of tissues, you have disappearance of whole labia minora, you have clitoral atrophy, clitoral hood phimosis,
Hmm.
you have narrowing of the opening, you lose the rugae, which the vagina is so important to have rugae that maintains lubrication and elasticity. And what you get is a whole lot of miserable women that are just told to use lube. Lube is fine. I love you, lube. Told to use lube and not given the golden ticket, which is vaginal estrogen. And the most important thing is it's a superbly safe. It's superbly safe. It's not systemic estrogen. So
Yep.
I was just telling a patient earlier today, a 92-year-old woman who I'm starting on vaginal estrogen. I said I have yet to meet a vagina that I couldn't give vaginal estrogen to. Um and if I ran the world, she wouldn't have gotten to 92 and just starting vaginal estrogen.
Right.
She would have been offered it as preventative measures by 50, by age 50. I'm 43. I started having recurrent UTIs. I started having pain with sex. I started noticing like that random vulva burning. And I promptly put myself on vaginal estrogen. And I'm 40. I'm not even gotten to menopause yet. And it makes
Yeah.
a big difference when I like miss my dose because I'm busy and I forgot or whatever, and I do that for a while. I notice the difference. I'm
Yeah.
like, oh, it's now it's a little burny, but so I don't play around. So anyway, I could talk your ear off if you
No.
let me. And yes, we did. I did have a very, very hard words for the pharmacists out there who refused to fill the vaginal estrogen cream for the patient because, so what was the reason?
She had a protein S deficiency.
That's the thing about vaginal estrogen. It doesn't matter. You've got a protein S deficiency, doesn't matter. You have bad blood clots, doesn't matter. You smoke, doesn't matter. You do we need to do progesterone in it? Nope, doesn't matter. You've had breast cancer, doesn't
Doesn't
matter.
matter. And you know what? And I have found, like, again, um, when we talk about even just the way we were created and born and made in God creation, however, that space, like the vagina, the cervix, vagina, rectum, they all like kind of just caved in, right, and created the different spaces. So, and the reason why that's important is because actually older women will start having those symptoms in the rectal area, so that
Yeah,
chronic
yeah,
dryness and irritation
yes.
around the anus and rectum that's unexplained. And so I put them on vaginal estrogen, and they actually get better. So they get, I mean, even, and then when I hear the frequent UTIs and they're like, oh, they were never able to, kind of get it, figured out. I'm like, no, you probably need vaginal estrogen. And give me another high five, because I tell them to throw away that applicator.
Okay.
Like, they have an applicator right here.
Here
Because
is the applicator.
yeah, they get that applicator, and then you put the vaginal estrogen in, and then what happens? They squirt it in there, and then what happens? You go urinate or you
It
poop, and it
plops right
it
out.
all it all comes right out.
Even
Like,
the
it's
even the
not doing
next
nobody
day.
nothing. Yeah, or you
Even
or it's all over your underwear. And I'm like, well, that's not where it's supposed to be.
yes.
So you got to get it in there and just swirl it around, rub it, and I don't even tell them, actually, for me, for colorectal. I actually don't even tell them to rub it around the rectal area, because it's a local hormonal disbursement that happens, that helps kind of rejuvenate that rectal area too, and restore the turgor of
Yeah.
the whole of the perineum and stuff like that.
Yes.
So I'm
So
like,
they
no,
don't
you don't put it
they
in
don't
your
have to
rectum.
put it.
Yep.
Yeah, like I love that. I love that you recognize that this is an extension probably of genital urinary syndrome of menopause. And when they're coming to you for like
I
the
call it the
rectal burning.
I call it the anogenital urinary syndrome. That's
I
my
love it. Let's do it.
yeah.
I'm all for it. And that you're like hormones, vaginal
Yeah.
hormones, safe. They should do it and they get better.
Well, and my thought process behind that is kind of weird. My thought process about why it should work, and this was even before I like read up on anything, is the concept. Let's talk about HPV, right? Let's talk about
Hmm.
how, women are twice as likely to get anal cancer compared to their male counterparts, and one and a half
Yeah.
times as likely to die. Why? Because in the U.S., women are trained to wipe from front to back.
Hmm.
So there's actually studies out there that, so they're auto-inoculating. They're passing the HPV to themselves from the front regions
Oh,
to the
oh, yeah,
nether
to that.
regions.
Sure, sure.
So whereas in, like, I think Latin American or Central American countries, they're taught to more dab, not necessarily wipe from front to back. So the statistics actually
And
have
then,
shown that
okay.
they have less rates of anal HPV infection compared to the US, and they have
Oh,
less rates
wow.
of anal cancer for their women compared to the US, by simple, nature of that. So I was like, huh. I was like, if it's that simple, then tell them to just use the vaginal estrogen, and it'll kind of help wipe the whole area.
Exactly. I didn't know that those statistics. That's very
Mm-hmm.
fascinating. Yeah,
Mm-hmm.
that's
Mm-hmm.
fascinating.
Mm-hmm.
Yep.
So, what would you say is like, we talked about vaginal estrogen. What's like one of the, I guess, the other hill that you would die on, in your space, when it comes to that, like that pelvic floor health, that you want, women to feel like, if they go to a doctor, if they go to someone who's not really listening to them, and they can go in there and just say it with your chest, like, what is it that they should be advocating for themselves for?
Ooh, just one.
Or a couple,
For
whatever. Let's
sure.
just
I mean, for sure. I always say this is like I will die and my tombstone will say vaginal estrogen saves lives or something like that. So I mean, that's like my two. That's number one.
Right.
I would say that um, really sex should be feel good. That it should not. It should feel good for the rest of your life. There's a lot of conditioning, a lot of acceptance of pain, a lot of acceptance of like enduring. I mean, I've literally had patients say, you got to endure, like, use some of the craziest words to describe intimacy to me.
Yeah.
And I'm telling you that the men don't do it. They don't, that's not it for them. Like, this
Yeah.
is not the experience that they're having. They are having enjoyable sex if they can until they die. And we are not. And we should not accept that. And part of why I'm so passionate about what I do and who I take care of in my office is because I really see the difference. I mean, I get to treat men and women. I can talk about sex all day long, and I see the difference, and I see how society prioritizes penis owners when it comes to their sexual wellness and completely neglects, gaslights, harms, even just straight up harms that vulva vaginal owners. So that's what I would say is like, do not take, well, that's just what it is, or,
Right.
well, that's normal, or, you know, as an answer
Yeah.
when
And
it
I'll tell
comes to
you,
pleasure. Yeah.
it's so funny. And I had a conversation with a couple, an older woman came in with some, rectal complaints, mostly regarding like irritation and itching. She was there with her spouse of like 40 plus years. Um, And so when I saw her kind of rectal area, I saw my anogenital urinary syndrome, and I knew it was just kind of roughed up from just chronic, lack of estrogen or whatnot. And
Okay.
so I started inquiring about it, and so I ended up, prescribing the estrogen for her. And so,
Yeah.
because I started to ask about like any urinary symptoms or vaginal
Uh-huh.
symptoms, and when I talked about, vaginal estrogen and what it's designed to do and what would help, like she literally cried because
Oh, wow.
she looked over at her husband and she was like, she's like, thank you for bringing this up because, um, intimacy is not comfortable for me. And,
Mm.
and so and I literally immediately felt the dynamic shift in the room, even
What? Yeah.
between her and her husband. And, when the shoulders are like this and now the shoulders kind of drop, they're like, kind of like, oh my gosh, you see me. Um,
Yes.
and so it's crazy how powerful, like we as surgeons, how we go in and we're trained, we're the technicians. We're gonna fix this,
Mm-hmm.
put this back together and make sure things good. But how satisfying it is just to say something as simple as I'm going to prescribe this is going to probably change your life. And so
Yeah.
yeah,
I call myself a neuropsychiatrist. Like I do a lot of procedures, but I do a lot of like like
counseling.
validation and psychosocial support.
Yep. Yep. And so it's funny because like I think we have our two subject matters are probably two of the most embarrassing or least talked about, right? In
Yeah.
medicine when we talk about, when you talk about intimacy, intercourse and all of those things, and me with like pooping in the butt. Like people are
Yeah.
just so fixated, And so when I tell people like you don't have to poop every day, they're like, huh?
Oh,
Like, so people are
yeah.
fixated, like, oh my God, I didn't
I
poop yesterday. So they're
know. They
downing
are
all these
really
medicines.
fixated on that.
Yeah.
Yeah.
And then they're like, oh, my stomach hurts. And I'm like, yeah, because you took all that stuff to poop every day
To
and you don't
do
need
every
to.
day. Yeah.
Like, it's
Who
okay.
told you
Like,
that was
who
what you
told you
needed
to?
to do?
Like,
Yeah.
just kind of like all of those things. And so, yeah, so we do find ourselves being counselors and psychologists
We
and
do.
just reversing years and years of like, the wrong
Dogma.
thought process,
Yes.
yeah,
Yeah.
dogma, wrong myths, and
Yes. Yeah.
whatever have been instilled in patients that just
Oh
don't make
yeah.
sense.
Oh yeah.
Yeah.
Oh
Hmm.
yeah. I'm
Hmm.
introducing women to their vagina and vulva for the first time. Some of them, I mean, some of them 60, 70. 40, years old here. You said this is the applicator. I remember one patient being like, my finger, isn't that dirty? And I'm like, no,
Yeah.
what?
Yep.
No.
Well,
Yeah.
listen, and I'm telling people the opposite because they're like doing all this stuff, overzealous hygiene, trying to clean and wipe. I was like, oh, isn't that going to affect it? No.
No. Do
That
less.
is the
Yeah.
rectum.
Yes.
That's where you poop from. It is
Yeah.
designed to not be clean. Now,
Yeah.
don't just leave it sitting there. I'm not saying that either. But like don't over clean because again, you disrupt that natural
Yeah.
flora, the the
Yeah.
the the normal bacteria that's down there to kind of keep
Absolutely.
things the pH balanced and all that stuff. But
Yeah.
yeah, so people are scrubbing they are scrubbing their behinds and I'm like, stop.
Stop it.
Stop.
Stop it. Yes. Yes.
Yeah. All right, so I'm gonna
Yeah.
just
What?
reintroduce everybody.
Yeah.
Just Sonia, just real quick, did you have any questions pop through about what we were just talking about, or are we okay to?
Yeah, I did. And hey, Dr. Milhouse,
Hey, Sonia.
so great to see you here. I do have a question from someone in the chat. It says, are there certain lifestyle changes when women should be more proactive about pelvic health or hormone-related changes other than age?
Repeat the question. Are there certain lifestyle changes?
Other than them just getting older, are there certain other things that they could do to ensure that their hormones kind of remain or they can hold on to them, or anything that they should be more proactive about pelvic health other than estrogen?
Okay, so are there other things they can do besides
Hmm.
vaginal estrogen?
Yes.
No, there's nothing like vaginal estrogen. Okay,
There
but
you go.
let me be okay. There is nothing that does what vaginal estrogen does. Okay, it's you can do other stuff, but it's not going to do what it does. And vaginal estrogen is a root cause treatment. Okay, there's a lot of things in medicine that we don't get to the root cause. Okay, you got this, we're going to give you this to do this, but it's not necessarily the root cause. This is one of those root causes. Okay, it's actually changing the architecture of your vagina, improving it. Why would you run away from it? Why? It doesn't make sense. Okay. You can, use the vaginal hyaluronic acid. You can use lube. You're not going to escape your hormones declining in your vagina unless you die. Okay.
Ooh,
You're not going to escape that. Like there's no prevention for menopause. Unless you die.
so actually, so let me ask you this actually, because when you were talking about hyaluronic acid and stuff like that, because
Yeah.
this came up this week, and I want you to tell us about some of the myths or the things that women are doing that they should not do. So boric acid, so that
Yeah.
came up this week in conversation with a patient that they were trying to use for vaginal health or whatnot. So tell us about boric acid and some of the other things that women are being maybe falsely told that are beneficial.
I mean, I like boric acid, but you can overdo it and it can burn and it is not, it's can reset your pH.
Hmm.
It can be um it can be a non-antimicrobial way of treating like
Sure.
mild BV and even yeast. Now, um it's not it's not the go-to for everything. And again, it can be overdone. Um, Hyaluronic acid is like a moisturizer for your vagina. It's over the counter. It's totally safe to use,
Hmm.
and it provides water retention and moisture. It's not going to change your architecture. I mean, it's not going to stop that labia from disappearing. It's not going to stop that blood flow that's now becoming constricted from continuing. It's not going to stop the progression. What happens in the vagina with age is progressive. It's not like hot flashes where you have it for a few years and you get through it and then you're good. Okay? As long as you have a vagina and as long as you get older, it's progressing. It's getting worse.
Yep.
Okay? It's not just for a season. Let me get through this season and then I'm good. It's getting worse as until you die. And so nothing does what vaginal estrogen does, period.
Thanks for that. Thanks for that. And so, is there anything in particular, and those who just joined, Dr. King-Mullins, also known as Dr. Tishy Touch Up, talking with the famous Dr. Milhouse, urologic surgeon in Chicago, down under urology.
Down
So, is
there.
there down there,
Yeah,
Lord, down under? I crossed the two. I'm down
it's
under.
okay.
Um, so tell me, or tell the audience what they should absolutely avoid.
For their vagina,
Yes. Is there anything that they should just absolutely avoid? Have you, anything that you can think of? Uh-oh, you're back.
can you,
We
can you
lost.
hear me?
Okay, got you now. Yep.
Yeah, my dad called.
Sorry. Hey, Dad.
So like it cut out the, yeah, probably to congratulate me on becoming president of Chicago Urologic yesterday.
Yes, we actually
Um,
mentioned that before you came on. I said we're gonna
Thank
welcome on
you.
the historic,
Thank you.
but yeah.
Uh, I mean, um, they should be weary or cautious with lasers.
Yeah.
And so lasers in the vagina were really promising at some point, and for improving blood flow, for increasing lubrication, for even treating incontinence. More recently, and I think there was a really good, more better quality evidence. It was like sham versus laser,
Hmm.
and it showed laser didn't do any. It didn't do the things we thought it was. Like it was no better than sham procedure, basically. The other thing is, in rarely, fortunately, rarely, it has had some more serious side effects, burning the tissues and stuff. So they should be cautious. I'm not saying don't do it outright, but just be cautious.
Hmm.
If it sounds too good to be true, anything, then maybe you should be cautious. Even vaginal estrogen, as much as I tote it and I think it's that bitch and that stuff, it's not a miracle like overnight miracle. It's a
Yeah.
long game. It's consistency. It's not going to, take you there to there instantly. Nothing will. So that's I mean, there's obvious things like, foreign objects that shouldn't go in your vagina, but like the lasers that are really direct consumer marketed a lot heavily and make a lot of grand promises, you
Hmm.
should just be a little cautious.
And
Any side effects? Somebody said any side effects. Can you clarify any side effects of what? I hope they're still there. Any side effects of
this
what? I don't
is,
know what they're talking about. Yeah.
I know that there was a question that came in about are there multiple brands of vaginal estrogen? The one that
Yes.
was prescribed has parabens. Are there any that do not have them?
You can get compounded formulations that don't have paraben. What was the uh I would say this. I'm gonna outright say this. If the brand you're on is Premarin for vaginal estrogen, you're spending way too motherfucking sorry, excuse me, I cuss. You're spending way too much money. Way too much money. Stop now and tell your prescriber, I don't want to be on Premarin. Switch me to something else. Premarin is expensive. It's I'm sorry, I'm gonna laugh.
like,
It's expensive. It's made from your pregnant horses. It's synthetic estrogen. I mean, it's just not. There's so many other just better, more way cheaper products out there. So no Premarin as your vaginal estrogen brand. Okay, no. I don't know, and if they're talking about estradiol, vaginal estradiol cream. having parabens, but if you're trying to get away from parabens for that reason, then there are you can get it compounded and it can be
Yep.
paraben free. Um Also maybe the non-cream versions don't have paraben. So okay, somebody said yes, that is. And I mean, um it's I'm not surprised it has it because it's a preservative. But there are that estradiol cream or creams in general are not the only way to get vaginal estrogen. You can get inserts. There are vaginal estradiol inserts, and that can be prescribed at your local pharmacy. That's not compounded. There's something called DHEA suppositories. Now I don't know if these things have paraben. I wish I had the answer, but you would have to check. But DHEA suppositories is a great option, even though that's like, where's the vaginal estrogen, Dr. Milhouse? You're talking about vaginal estrogen. What's DHEA? DHEA is a precursor to estrogen and testosterone. And if you were here earlier, you heard me say something really quickly. I said you really need both in your coochie. Okay, your coochie really likes both hormones, the estrogen and the testosterone. So if we're being really real, having both is actually the winning tick, the like elevated ticket. But at minimum, you need the vaginal estrogen. Okay, it's just that there's no commercial product out there for estrogen and testosterone. You either have to get it compounded, or you can do something like DHEA to get to get the benefit of
To
both.
the benefit of both.
Yeah.
Okay. Yeah.
I do have one more question here. How common does, and I think Dr. King-Mullins, you kind of touched on this before Dr. Milhouse popped on, but how common do you see urinary incontinence patients that also have fecal incontinence?
I don't know what the numbers are off the top. It's more common than we probably see. I always ask about fecal incontinence with my urinary incontinence. Fecal incontinence, I mean incontinence of any kind is really tends to be an understandably embarrassing issue for people to even admit to their physicians.
Mm-hmm.
And
Yep.
fecal incontinence in particular seems to be like even more embarrassing. So I suspect that there are some people who don't tell me the whole truth.
Yeah.
You know, they're like, I ain't ready to admit that.
Right.
Um, but do you know that? Do you have the numbers? I feel like there has been some. Let me
Well, I
ask.
mean, I
Okay,
think
yeah,
so. We said before, like there's about 1 in 12 persons, adult
okay,
persons, experience fecal incontinence. Just like they'll admit to fecal incontinence. But I'll
yeah.
probably say, a minimum of 50% of my patients who come to me for fecal incontinence and I inquire about urinary incontinence, a minimum of 50% are going to say, "Yeah, I have accidents there too." But the funny thing is, like a lot of times for the urinary incontinence, just like you were saying, like the level of embarrassment factor, they'll just accept that. They're like, "Yeah, I wear a pad," and I'm just like. Well, I mean, we can
We
let's
can
talk about that
help.
too. Like,
Yeah,
let's talk about that too. Like, it's
yeah,
okay.
yeah,
Yeah.
yeah.
Um,
So the literature matches up with what you're seeing. About 50% of people with fecal incontinence also experience urinary incontinence.
yeah.
Um, I don't know what it is for the flip side, like how much of the urinary incontinence is uh, are experiencing fecal incontinence. Um, Anecdotally, it's maybe 10% at best from what I'm seeing, but I wonder if there isn't people who don't admit to it.
Right.
I really suspect this is
Yeah.
underreported. Yeah.
Yeah. Um, So I want to kind of circle back and kind of go off topic just a little bit, something when Dad called in, because we did bring that
Oh
up
yeah.
before you came on, that we would be welcoming on the newly voted in president of the Chicago Urological Society. So from what I understand, only the fourth woman to ever hold that position, first African American woman to hold that position. So tell me what that role looks like, what that society does, what it means to you, because I'm, so proud of you.
Thank you. Oh, it's a huge honor. The Chicago Urologic Society is one of the oldest. urologic societies in the country since 1903.
Wow.
Okay. And it has some of the greats in urology. Charles Huggins, who is profound in determining and finding PSA, prostate cancer. Okay. Um, was a president, past president, was involved in Chicago Urological Society. Um, Not only that, it's one of the best, if not the best, I think, Chicago urologic societies in the country in the quality of its sessions, quality of what it provides.
Yeah.
The collegiality, we have visiting professors that are world renowned, and just the immense network. I mean, when we say Chicago Urologic Society, we don't just mean Chicago.
Right.
We are including all of Chicagoland, surrounding suburbs and everything. We're including Northwest Indiana. We have people from Indiana. We're
Yeah.
including Wisconsin. We have people from Springfield,
Yeah.
um, from Champaign, come in. So it is really a massive network. In Chicago alone, there are seven, I think, like academic institutions.
Yeah.
Um, and so we have tons of trainees. And so it's super instrumental within the community. It is very much as urology is, and historically and still is, a boys' club.
Yep. Yep. Yep.
This
Yep.
is a boys' club. Okay. I mean, if you were to walk in a meeting today, you would still be like, okay, this is feeling like an old school boys club. Okay. Um, and that's yeah, it's largely men. It is largely white men. It has been that way for eons and eons and eons and eons. Men, 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 men. I mean, I started going to these meetings when I was a resident, and I would sit in the back, and I'd be intimidated as all get out. I was like, I don't ever want to speak at this. I'm here to learn. I'd soak it up, and I was like, I don't ever want to
Right.
speak at this meeting. And to find myself now leading this group of individuals, um and I feel very like it's with like very welcome. I wasn't voted to correct you. It's not a voted thing. It's
Oh,
an
sorry.
appointed thing. It's
Appointed. Oh,
appointed.
oh, awesome.
Yeah. um but I am like, I'm just so honored to follow the footsteps. It's a very prestigious organization. It's amazing to see the, like, again, the list,
Yeah.
and to know here's this little black girl who didn't think she could even be a urologist. When I first heard what urology was, I was like, "Good, cross that off my list. Black girls don't do that."
Right.
To think I'm serious. In med school, I said that to myself when I first heard about it. I was like, black girls, what is a black girl going to do in urology? That was my issue. To think that little black girl now is Madame President for the next year of Chicago Urologic Society. I'm still pinching myself. I can't believe
Yeah.
that it's true. So thank you.
Well,
Yeah.
amazing accomplishment, so well
Yeah.
deserved.
Thank you.
Like I said, coming off of Women's History Month, just yeah,
Yeah, that's so true. I
accomplishment
didn't
is
even I
so well deserved. Yeah.
Yes, it is. It is.
Awesome,
Thank
awesome.
you.
So this has been a great conversation tonight with Dr. Milhouse, newly installed president of the Chicago Urological Society, from down there, not down under, down there, urology in Chicago. So we're going to start wrapping this up, this next installment of our series of The Love Below. So give us some parting words, Dr. Milhouse. What do you want all of our audience to walk away from this conversation understanding?
I hate when people do this. I'm like, party word.
Come on, just be like. No, just kidding.
Um, it's been great. Thank you so much. I want to just say thank you for putting this together. Thank you for caring enough. Thank you for being the boss surgeon, physician that you are. I'm so sad. I'm sorry that I was late. You know, it
But you were
happens.
doing boss surgeon things,
I
so
was taking
so
care of
I'll
patients, being the neuropsychiatrist that I am. My parting words is that you matter and your problems down there matter, okay? Don't just live with this, okay? Don't just accept this as your new normal when there are many things that we can do. And there are going to be a lot of, there might be people who gaslight you and tell you, and these, to tell you, yeah, that's just, yeah, there's nothing you can do about it. That's just the way it is. Get a second opinion.
yeah,
Don't take no for an answer
yeah,
when it comes to your pelvic wellness and health, because it is extremely important, and you deserve that much.
yeah. And get a third and a fourth opinion if you have to.
Yes, absolutely. Even if
Yeah,
somebody says sees me, I'm like, listen, don't stop with me. Get some another
yeah,
opinion too. Yeah.
yeah, yeah. Oh, real quick, I just wanted to make sure,
Oh,
Sonia, were there
two
any other
society presidents.
questions?
What's your president too? Who?
Oh, the Society of Black Colon and Rectal Surgeons. Thank you, thank you.
I
I'm really
love
bad.
it.
I can't see the
Look at.
comments. I'm like, what?
Oh, you can't see them.
Of course, I don't know. For some reason, like, I don't know. I'm on my phone. Am I supposed to see them on my phone?
You are.
I
You're
say,
supposed to see them. Yeah, yeah,
yeah,
yeah.
I'm bad. I'm like, this is why, listen, this is why Sonia is in
It
charge.
is monitoring the site. Yeah, yeah, yeah.
I pretend like I'm all tech, but
Yeah, yeah,
I'm certain tech. I'm certain tech.
I'm
yeah,
gonna have
yeah.
to I'm gonna
But
have to come into the office and take over your phone.
but are there any other questions or comments that came through, Sonia, before we close out?
Yeah, there was just one more, and actually, it's
Sure.
probably a good, somewhat closing question about like where do you all feel like you end up overlapping in a collaboration the most? So it was talking about how there's constipation and urinary issues and things like that. We see those symptoms, but how do you know when they overlap, or are there two issues or one, or when do you all like call on each other for that insight?
I
Yeah.
feel like we overlap a lot.
Yeah. Probably
Like
even
like
more than
everything.
yeah, I think probably even more than we get to, because sometimes when you're being that like Euro psychiatrist and stuff like that, you get to the certain point like I can't ask about anything else because we're gonna be here for
Mm-hmm.
another hour.
Mm-hmm.
But
Mm-hmm.
but
Yeah.
yeah, I think there's quite a bit of overlap, probably a lot more um, than than we anticipate,
Then
and so
yeah.
and that's
Yeah.
one of the reasons that I really like to employ pelvic floor therapists earlier on, because they have, I mean, they legit have more time and discernment to maybe figure out some of the overlaps sometimes even in a deeper setting than we can in our allotted times to see patients in the office. What do you think?
100%. I mean, I feel like there's undoubtedly bowel symptoms when I see somebody who has overactive bladder or leakage. When I see somebody who has bladder pain, interstitial size. Man, almost all of my bladder pain patients have IBS.
Yeah,
It's like you got bladder pain, you have IBS. Okay. I feel like for the pelvic organ prolapse, a decent amount also have some fecal issues or rectal involvement.
yeah.
Um, so many. Like
Yeah.
we said with GSM, you've now said it called the anogenital urinary
Genitals.
syndrome. Yep.
Hmm.
Yeah. So in most things we overlap.
Yeah.
Yeah.
So. So yeah, so closing on that, if you experience any urinary symptoms, please be cognizant and think about any particular colorectal symptoms that you may have, and vice versa, because there is so much overlap, and that will help guide your discussions with your physicians a lot better, if you just fully understand that there's a lot going on down there. So
Yes,
discuss, and I don't think it's necessarily the patient's fault. I think they compartmentalize, because a lot of times we as doctors say, well, that's not my area, talk to this person, that's not my area.
exactly.
And so
Agree.
I think what we do, we actually, elicit more of that information than they probably do from some of their other doctors and providers or whoever they're seeing. So just make sure you talk
Totally.
about all of it. Yeah.
Totally. Yeah.
Cool. Well, it's been
Awesome.
real, Dr. Millhouse. We'll have
Thank
to
you
have you back
so
on in the
very much.
future.
Yes, yes.
Uh,
Maybe a little bit later so I don't mess things up, but I would
no,
love
no,
to.
no.
Yes.
You're good. You're good. We could definitely move it back. And there was a brain freeze on my part, realizing like, oh yeah, you are Central Time, but we'll
Yes.
get it
Yeah.
together.
It was a mutual brain freeze.
Yep.
All right. Have a good night,
All right.
everyone.
Bye. Have a good
Bye
night. Thanks
bye.
for joining us.